Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. Tonight's presentation is titled An Introduction to ADHD for Parents. And our presenting providers are Trinity Health IHA Medical Group Pediatrician Brittany Raburn, who sees patients at our West Arbor practice in Ann Arbor, and Behavioral Health Specialist Lauren Cox, who sees patients both virtually and in person at our Chelsea practice. Welcome.
Thank you. I do just want to make a correction. Lauren, actually, she'll see patients at virtually and then at the Domino's Farms location.
Thanks, Dr. Raburn.
Thank you.
Right. Thanks for bearing with me with playing presenter tonight. My first go at this, so let's go ahead and get started. We wanted to start out just with a quick introduction, let you know a little bit about us. I've been a practicing pediatrician for close to 9 years, 5 of which have been with IHA at the Chelsea location, actually. I just recently transitioned over to the West Arbor location this month. I did my pediatric residency training at Cincinnati Children's. During residency, I elected to do the primary care track, which allowed me to spend some dedicated time with the child psychiatrist there. This experience piqued my interest in ADHD medications, given that they can lead to a dramatic improvement in the lives of so many patients and their families. I have an undergraduate degree in neuroscience, which has helped provide a foundation for my current clinical interests in mental health in the primary care setting. I do want to point out that I am not an expert in ADHD, nor am I a psychiatrist. Due to the large number of children with ADHD, the mental health system simply can't accommodate all of these patients. So as general pediatricians, we often initiate the diagnosis and management of ADHD and refer when further consultation with psychiatry is needed. Our talk tonight will be limited to the scope of ADHD as it presents in the primary care setting. On that note, I'll let Lauren introduce herself.
Thanks, Dr. Raburn. My name is Lauren Cox. I have my LMSW, which stands for Licensed Masters of Social Work. I earned my undergraduate at Eastern Michigan University with a minor in criminal justice, and I continued at Eastern Michigan for my master's in social work with a concentration of children and families. I have been in the practice for about 6 or 7 years now. 2 of those have been at IHA. I recently transitioned to the Domino Farms location, but prior to that, I was at the Chelsea location and West Arbor location as well. So first off, we'll start by talking about just what are we going to cover this evening. First off, we'll have what is ADHD and then provide an overview of the evaluation process. Next, we'll look at the different type of treatment for ADHD. Then we'll lead into some different strategies and techniques that can be helpful to utilize or practice. And then lastly, we'll talk about some resources and additional support that may be helpful for parents and families.
So what is ADHD? We'll start the night out by describing what ADHD may look like, how we make the diagnosis, and what other disorders we consider before making the diagnosis or the differential diagnosis. So attention deficit hyperactivity disorder, ADHD, is a chronic condition that can make it hard to sit still, pay attention, or make good decisions. ADHD can cause a child to have trouble in school, at home, or with friends. People with ADHD have trouble with a group of key skills known as executive function, and that creates challenges in many areas of life, including school and everyday living. For example, people with ADHD often struggle to get organized, follow directions, and manage their emotions. ADHD is one of the most common disorders of childhood, occurring in approximately 10% of children. It is 2 to 4 times more likely to occur in males, especially the hyperactive impulsive type. ADHD often continues into adulthood. The cause or causes of ADHD are not definitively known, but studies have shown that it is likely a neurodevelopmental disorder that leads to an imbalance in chemicals in the brain. There is most likely a genetic component to it, given that ADHD tends to run in families. There is also some evidence that prematurity and prenatal exposure to tobacco can increase risk of developing ADHD. It is unlikely to be caused by dietary factors such as food additives, sugar, or mineral deficiency. So these developmental changes and chemical imbalances within the brain manifest as the symptoms we see in children with ADHD. So children with ADHD have one or more of the following symptoms: inattention or difficulty paying attention to details, hyperactivity or increased activity, or impulsivity or acting before thinking things through. I'd just like to point out the different colors, the green and purple, which will help distinguish the different presentations of ADHD that are recognized, and we'll discuss this more later. It's also important to note that these symptoms can change over time as the child develops. Inattention may take many forms. A child might be forgetful, lose things, have trouble finishing a project, have poor follow-through with assignments or tasks, be disorganized, have poor concentration, or poor attention to detail. Symptoms typically become more obvious in school when a child may be expected to pay attention and sit still around 8 to 9 years of age, although symptoms may be apparent at home at a much younger age. Inattention is most likely to persist throughout adolescence and potentially into adulthood. Hyperactivity might look like a child who has trouble sitting still or playing quietly, has difficulty remaining seated when required to do so, always seeming to be on the go, or have excessive talking. Impulsivity might look like a child who interrupts others or intrudes on others' activities, has difficulty waiting turns or blurting out answers too quickly, or has disruptive classroom behaviors. These symptoms are usually seen by age 4 and peak around 7 to 8 years of age. Hyperactivity may be less noticeable into adolescence, but impulsivity usually continues throughout life. While almost all children can have symptoms of ADHD at times, it is the persistence, pervasiveness, and functional complications that lead to a diagnosis of ADHD. So as physicians, we diagnose ADHD by the specific criteria set forth in the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, written by the American Psychiatric Association. We must see 6 or more symptoms of inattention and/or 6 or more symptoms of hyperactivity impulsivity. These symptoms must occur often. They must be seen in more than one place, for example, at home and in school. They must be going on for at least 6 months and start before the age 12. They must negatively affect schoolwork and/or relationships. They must be in excess for the developmental level of the child, and they can't be caused by other mental disorders. The DSM-5 recognizes 3 presentations of ADHD. A child may have ADHD inattentive type, previously known as ADD, or ADHD hyperactive impulsive type. Or if they have 6 or more symptoms of both groups, we will diagnose ADHD combined type. About 50% of children with ADHD have other disorders, such as learning disabilities, disruptive behavior disorders, anxiety, mood disorder, developmental coordination disorder, or trouble sleeping. ADHD can also co-occur with autism spectrum disorder. A child with a coexisting condition may require the care of a specialist, such as a psychiatrist and/or a psychologist. Lauren will elaborate further on these different disorders.
When we look at differential diagnosis, we typically focus on these 4 areas, whether that's anxiety disorders, so looking at the difficulty of managing the racing thoughts or worrying thoughts that a child might be having, looking at mood disorders, so that can impact our motivation, which then inevitably impacts our task initiation and our completion, conduct disorders, so looking at challenges surrounding socially appropriate interactions or following the rules, oppositional defiant disorder, that can be an ongoing pattern of emotional reactions surrounding authority, so parents, teachers, things like that, When we look at differential diagnosis, we want to keep in mind that individuals are unique and complex, especially when we take in consideration the developmental stage a child is in. So it's important for us to bring awareness to the different factors that can look similar to ADHD. That then is going to take us to how do we see it presented. So when we think of anxiety symptoms, we may see some irritability, worrying thoughts. That can look like restlessness, which then can look like the hyperactivity of ADHD. When we look at our mood, that can include negative self-talk, avoidance behaviors. When we see that overlapping or similar to ADHD, we can think reservation to do something, maybe refusal, so it can look a little bit similar. If we think of the social skills and then the consequences of a conduct disorder, if a child is receiving consequences at home or at school, that can create negative self-beliefs, which then results in distractions or difficulty concentrating in a classroom. And lastly, oppositional, whether that's following directions or having emotional reactions to anger, that impacts our active listening, impacts our concentration, and then our emotional reactions. So keeping in mind that all of these can be overlapping or have some similarities, that is going to lead us to our next topic of evaluation to say, where do we go from here?
Technical difficulty. So the next topic we'll talk about is what the evaluation process may look like, including Vanderbilt forms, clinical interview, and psychological testing. So if you think your child may have ADHD, the first thing you'll want to do is talk to your child's teacher. This will help to determine if your child has difficulties in more than one setting. And sometimes the teacher will approach the family first with concerns. Next, talk to your child's doctor. Your doctor's office will help you navigate the next best step. So there's no specific test for ADHD. It's not like we can order an X-ray or an MRI or a blood test. Instead, evaluators use a variety of tools to determine if a child has ADHD. One of these tools is a questionnaire about behavior, and another is a clinical interview. Vanderbilt's evaluate symptoms of ADHD according to DSM criteria and screen for other conditions such as ODD, anxiety, depression. Typically, your doctor will review the Vanderbilts prior to the clinical consultation. At the visit with your doctor, plan to discuss your child's symptoms and review the medical, developmental, educational, and family histories. Typically, a physical exam will be done, and this might also be a good time to check hearing and vision if that hasn't been done already. This may take several visits with more than one provider. Some types of professionals who may diagnose ADHD include your child's family doctor or pediatrician, psychiatrists or psychiatric nurse practitioners, developmental pediatricians, neuropsychologists, or clinical psychologists. Psychological or neuropsychological testing is not always necessary, but can help to exclude other disorders or tailor interventions for the individual. Psychological testing, sometimes called cognitive or academic testing, can help exclude other disorders such as learning disorder. It can also identify specific problem areas for children with ADHD, such as executive functioning skills like abstract reasoning, mental flexibility, planning, and working memory. The public school system is often the best place to obtain basic psychological testing, though more specialized neuropsychological testing requires consultation with a specialist. Neuropsychological testing adds the direct assessment of attention and hyperactivity impulsivity. This specialized testing is often desirable to fine-tune treatment plans for individuals. At the West Arbor location, we typically start with Vanderbilt forms, and once these are reviewed, we'll determine whether consultation is warranted in the office with a provider or if the child should be referred for further testing, such as neuropsych testing. Next, we'll move on to the treatment of ADHD and the different modalities we utilize, such as interventions at school, behavioral treatments, and medications. So once the diagnosis is confirmed, the outlook for most children who receive treatment for ADHD is encouraging. Treatment can help improve a child's symptoms and improve self-esteem, have better relationships with others, perform better in school, such as finishing schoolwork and decreasing the risk of dropout, as well as decreasing the risk of unintentional injury. Depending on the child's situation, one or more of the following treatments can be used: changes at school, behavioral treatments, or medication. Behavioral treatments are started first for preschoolers aged 4 to 5, and medication is considered first-line therapy for school-aged children 6 and above. However, optimal care is likely to occur when all treatment modalities are combined. I also want to highlight the interplay between treatment modalities. Often, medication helps by controlling the core symptoms of ADHD, thus allowing the child to sit and focus long enough to learn the behavioral techniques. However, once the medication stops, the positive effects of medication do not persist, but the positive effects of behavioral therapies do tend to persist. So next, Lauren will talk about the changes that can be done at school and behavioral treatments.
So when we think about school interventions, we want to start off by exploring what the school may have to offer. These interventions can consist of specific programming, collaboration between school staff, family members, and even community agencies. So when we look at those different interventions, they could include a behavioral management plan, which is a plan created for looking at steps and techniques for potential challenges. That can include replacement behaviors to promote appropriate classroom conduct, or having alternative measures put in place so that the child is spending the most time in the classroom. Schools can also focus on organizational skills, also study skills or groups, so learning those interpersonal skills to be able to work as a team or being able to keep track of different assignments. We see in elementary classrooms that we often have, they often may have behavioral charts or systems. So sometimes that can be like a color chart for different behavior levels or even moods. Sometimes there's token systems to promote positive behaviors. Something we want to ensure when a behavioral chart or system is used is that the goal is reasonable for the child to obtain. So when we think, if, for an example, staying on the reading rug for the whole time during reading, or a token is given each time a hand is raised, rather than staying in your chair the whole day or not talking out of turn all day. If we think of a child with hyperactivity, staying in a seat all day may not be reasonable, and they may lose that motivation to work towards that goal. So we want to make sure that they're reasonable. Lastly, we want to look at the accommodations and plans. So these are a large factor in school interventions to ensure students' needs are met in their educational environment. In a little while, we'll actually dive a little bit deeper into the accommodations and the process of plans within the education system. Outside of school, we're going to look for those evidence-based practices for ADHD treatment. In any behavioral treatment, the expectation is to learn management techniques for the challenges that are presented by a condition, not necessarily just to eliminate any indication of it. So when we think of behavioral health therapy, we are going to look at individual therapy can include parents to encourage and promote the practice of learned strategies, which those can look at emotional regulation, executive functioning skills, routine and sleep hygiene. There can be the aspect of bringing awareness to the emotion, thought, and behavior process and how those all connect. Looking at reframing of beliefs and assumptions to promote replacement or more appropriate behaviors. And then lastly, skills to promote that concentration and focus. Outside of individual behavioral health therapy, there's also parent training, which is a treatment option to provide psychoeducation, look at parent-child interactions, and then teach strategies to implement in the home. These strategies may focus on behavioral modification, positive reinforcement, and then rewards and consequences as well.
Okay, next I'll talk about medication as a treatment for ADHD. So medication is not a tool, or is a tool, excuse me, not a cure. A dad of a child with ADHD gave me this analogy, which I really like. He said the medication acts as a ramp to allow his child to access improved executive function skills. But once that ramp is removed, the child has more difficulty accessing that skill set. He likened it to what insulin is like for diabetics in their pancreas. Treatment for ADHD uses the same principles that are used to treat other chronic conditions like diabetes, since these conditions are not cured. Long-term planning is needed, and families must manage medications on an ongoing basis. In the case of ADHD, schools and other caregivers must also be involved in managing the condition, as Lauren has discussed already. So the good news is that medication works well for around 80% of people with ADHD. However, finding the right dose may take several months and requires close monitoring. This process is often referred to as titrating or fine-tuning. During this process, we monitor for side effects while we try to optimize the efficacy of the medication. While weight-based dosing can serve as a guideline, the genetic differences and individual metabolisms of these medications requires individualized dosing. So this is a trial and error process. Your child may need to try more than one dose and/or type of medication to find the dose and medication that works best with the fewest side effects. The good news is that most side effects are mild and go away after a few weeks. While treatment for ADHD should improve your child's behavior, it may not eliminate the symptoms completely. Children who are being treated successfully may still have trouble with their friends or schoolwork. Our goal is reduction in core symptoms by 40 to 50%. For example, decreasing the proportion of missing assignments each week from 60% to 30%. We can utilize follow-up Vanderbilt forms or daily report cards or periodic narratives from the teacher to help gauge improvement if that's needed. If your child clearly is not improving, your provider will reassess the treatment plan. So when I talk to families about medications for ADHD, I like to start by differentiating between the two main categories of medications, which are the stimulant medications and the non-stimulant medications. In the stimulant medications, you may have recognized the brand names Ritalin and Adderall. In the non-stimulant medications, you may have heard of Intuniv, Guanfacine, and Strattera. And before we talk more, I want to reassure you that stimulants do not cause children to be more active or excited. They help brain cells communicate to improve attention and self-control. Stimulants are considered first-line treatment for school-age children, but sometimes a non-stimulant may be started due to potential side effect or other circumstances. Both categories have long and short-acting formulations, as well as formulations that can be swallowed whole or dissolved, chewed, or sprinkled. Other factors that might determine which category to start with could be the potential for side effects, or if there is a specific target symptom in mind. The desire to take a medication every day could affect which category we start with, since the non-stimulant group of medications requires everyday administration, and some families may prefer the flexibility of dosing that stimulant medications can allow. Finally, a notable distinction is that stimulant medications require a Schedule II prescription, meaning that there is potential for abuse or misuse of these medications if they are not taken as prescribed, and therefore prescribers are mandated to monitor and refill these prescriptions on a monthly basis, meaning you'll need to request a refill of stimulant medications from your doctor each month. In the following slides, we will discuss the medication groups in more detail. So to start out with, the stimulant group. Stimulant medications fall into one of two main groups: methylphenidate, such as Ritalin, Focalin, Concerta, and amphetamines, such as Adderall or Vyvanse. Stimulants have been used to treat ADHD since the 1930s. Millions of children with ADHD have used stimulants, and very few have had serious side effects. So how do they work? Stimulants increase the availability of certain chemicals in the brain that play an important role in attention. These chemicals are called neurotransmitters, specifically dopamine and norepinephrine, and they work by facilitating communication or boosting the signal between brain cells at their connections called synapses. These medications start acting fairly quickly, and their effects can be seen in as little as 30 to 60 minutes. The most common side effect that I see in practice is that patients may stop feeling hungry, which can lead to skipping meals, especially lunch. Less common side effects include headache, stomachache, trouble sleeping, social withdrawal, irritability, tics, or poor growth. Poor growth may be decreased weight due to the decreased appetite, or we may see a slight slowing of linear growth. The effects of height are debatable and are only on the order of 1 to 2 centimeters of full adult height. Rare serious side effects may include cardiovascular risks, and a small number of people may develop suicidal thinking, hallucinations, or aggressive behavior. Cardiovascular risks are mainly concerned with the potential for increase in blood pressure and/or heart rate. Your doctor will review these risks with you and may consult with a cardiologist if your child has a serious heart problem. As I mentioned earlier, we can discontinue these medications abruptly if needed or desired for medication holidays, meaning that your child doesn't necessarily have to take them on weekends or over breaks. And lastly, they do require a Schedule II prescription, meaning that you will need to contact your doctor's office monthly for a refill to allow for close monitoring, given the potential for misuse. So moving on to the next category of medications, the non-stimulants. So under the non-stimulants, we have two main categories as well. Unlike the two categories of the stimulant groups, the methylphenidates and amphetamines, those are very closely related. The non-stimulant medication, these two categories here are completely separate. So we'll look at these on different slides. The first group of the non-stimulant medications that we'll discuss are the alpha-2 adrenergic agonists. These medications come in two forms: guanfacine, branding for the immediate release is Tenex, and the extended release is Intuniv, and clonidine, branding for the immediate release is Catapres, and for the extended release is Capve. These medications can be used alone or in combination with a stimulant medication. So how do they work? These medications were originally designed to lower blood pressure. However, they found they didn't work very well to decrease blood pressure, but it was noted that these medications helped improve symptoms of ADHD. It is thought that these medications stimulate certain receptors in brain cells to help regulate activity in a part of the brain called the prefrontal cortex that is used for executive function skills such as planning. In practice, I use these medications more for the hyperactive impulsive type of ADHD, but there's growing evidence that they are effective for inattentive symptoms as well. These medications can also be helpful in children with a history of tics or sleep disturbances. It does take longer for a response time with these medications, typically on the order of 1 to 2 weeks. The most common side effect we see with these medications is sleepiness, especially in the first 4 to 5 days after starting the medication. Other less common side effects can include headache, stomachache, dry mouth, dizziness, or irritability. A rare serious side effect would be lowering blood pressure. Lastly, these medications need to be stopped slowly due to a theoretical risk of increasing heart rate and blood pressure. So there is not an option for that medication holiday or break in medication. Excuse me. Moving on to the second main category of non-stimulant medications, which includes atomoxetine or Strattera. This medication works as a selective norepinephrine reuptake inhibitor, which just means that it increases the amount of norepinephrine at that brain connection, that synapse, which again leads to increased attention. Again, the time for initial response is going to be on the order of at least 1 to 2 weeks. The common side effect, much like the stimulants, is not feeling hungry. Less common side effects include nausea, trouble sleeping, or tics. And rare serious side effects may include a small increased risk of suicidal thinking, hallucinations, aggressive behavior, or liver injury. Excuse me. So if medication is used, it is important to talk with your child about the medication and why they take it for ADHD. Talking with your child about the medication can help them understand why they need it and what to expect, as well as preparing them to assume more responsibility for treatment as they get older. While it is important to involve the child in the conversation about medication, an adult caregiver at home or school should be in charge of actually administering the medication. None of these medications are appropriate for a child's backpack. Moving on to strategies and techniques, which Lauren will cover.
All right, so from a behavioral health standpoint, we're going to look at different strategies for home, for school, and then specifically within social interactions. So starting at home, we know that life is busy, hectic, and it's full of unexpected changes. So when families are able to create consistency within routine, it provides children with structure. So this consistency can look like scheduled tasks, whether that's wake up, bedtime, having a designated time for homework, having screen limits. If you know there's going to be a routine that's interrupted, try to plan ahead. So this may look like, all right, we're going to get home later tonight, so let's pick out your clothes tomorrow before we leave. So we're not trying to do that right when we get home and our bedtime's already started. We also want to look at informed plans. So sharing with our child what is expected, what are we going to be doing, how long are we going to be doing that for, and then how do we prepare for that? What are some things we need, whether that's school, sports, is your cleats in your bag, just having some type of dialogue about what to expect and all that we may need. I talk a lot about in therapy with families that consistency doesn't mean perfect. So when there are manageable changes or unexpected changes, this actually provides children the opportunity to learn flexibility, because we know in life, not everything goes as planned. So this can be helpful to teach those moments of how do we kind of roll with it. Additionally, at home, we want to look at de-escalation. So at the end of every day, we are all humans, which means parents get frustrated, they get stressed, they get exhausted too. It is really important to show your child that you're there for them when their feelings are just kind of too big for them. So when we think of de-escalation, how do we practice keeping our composure? So whether that's me walking away, it's not about I'm leaving you, it's more of I'm leaving the situation. Keeping in mind that anger does not put out anger. It is hard when a kiddo is screaming at you, throwing a tantrum, right? But doing your best to model some of those behaviors of saying, okay, I see you're frustrated right now. I'm going to give you a few minutes to yourself, which also gives you those few minutes to collect yourself as well. Validation without feeding the emotion. So sometimes validating a child's emotion can be hard because it feels like we're agreeing with it. That's not what it means. It's actually showing your child that you understand them, and in return, they feel more comfortable being open with you with their emotions. And then lastly, for de-escalation, how do we provide an opportunity for appropriate control? So as humans, we all have an emotional need for control. So when you provide a child with an option, they are given the chance to meet that need of autonomy. So that can look like, would you like to sit alone for a few minutes, or would you like me to sit with you? Kind of giving them that option of what would they like to do with those moments. And when we also think about expectations at home, whether it's a list of chores, a multiple step direction, even giving a kiddo an idea of what time we're leaving the house, we are setting expectations of kids quite frequently. So we want to make sure that we're setting them clear and that they're reasonable. We can practice this by getting their attention. So having them pause whatever they're doing, making eye contact that can promote the active listening skills. Even having your child repeat back the direction or instruction, that activates our working memory. So that's setting with them, yep, I know what mom or dad or whoever just asked me, what they just asked me to do. Looking at following through on rewards and consequences, those can look different between families, and rewards don't have to be monetary. I know I hear all the time, like, if I do this, can I get some Robux or whatever that may look like? But it doesn't have to be that. We can keep in mind that like positive affirmations, even validation and allowing different decisions can be rewarding too. Natural consequences are also very important. So when we interrupt a natural consequence, that actually creates reinforcement for challenging behaviors. So for an example, if we set an expectation that we are cleaning up a board game before we go play outside, it can be really difficult for any child, but also a child with ADHD symptoms, to stop and clean up a board game when they're already really excited to go outside. The difficult part is when we say, all right, fine, we can do that later. This then tells the child's brain, I still got to do what I want without having to do what I was expected to, which makes it difficult. So if we use natural consequences and word it in the way of, if you'd like to go outside, please clean up the board game first, that gives the child the choice of saying, okay, if I don't clean up, I'm not going outside. So kind of following through with those. And keeping in mind that ADHD can impact building these habits, so parental support is crucial in building the mastery of whether that's tasks or routines. So sometimes in sessions we hear that, like, they should be able to do this. Why am I always reminding them of this? And just realizing that there can be some deficits and just challenges with these executive functioning. So even just being supportive and helping them learn those tasks to be able to then build them on their own. And lastly, visual reminders. So I know giving constant reminders can become tedious and daunting for both the child and parent. So as much as verbal reminders are important, so are the visual ones. This can be checklists, charts, pictures, sticky notes, anything that then allows the child to take those steps on their own. That can provide a sense of independence, also while the parents are there encouraging to make sure those tasks are initiated. To switch over to school strategies, so some supportive strategies for attention challenges can be increasing individual participation. That may be using name sticks of who's gonna answer the next question, or even just having the teachers engage students with questions. Looking at specific seating arrangements, so that can be upfront or that can be near a supportive classmate. Also having students involved in lessons, whether that's writing on the board or collecting handouts, whatever that may look like, just having them engaged with the lessons. For hyperactivity, we know kids like to move, so it can be helpful to allow small breaks to get up, get those wiggles out, having teachers check in on a task prior to giving more. So if we have a packet of 3 pages saying, hey, come check in with me once you finish page 1, so then we can move on to the page 2. We can see that if it feels like way too much, whether it's 3 pages, that's just overwhelming for a kiddo and they might get distracted, they might lose concentration. Also allowing appropriate movement. So this can be a class runner or helper, having students stand while they're working or move to a different location. Talking back to that specific seating arrangement, sometimes it can be helpful for a kiddo in having a seat in the back of the class if they're able to concentrate, so they can get up and kind of move around without disrupting the rest of the classroom as well. Lastly, for school, we want to think about communication. So that is more than just the words we use. It is key to make sure that that's the teacher and the student, parents, everyone is on board with what's going on. So a strategy that can be helpful is using a discrete signal to get a student's attention, whether that's to refocus, if there's a disruption happening, or even a distraction. The nice or positive thing about a discrete signal is that it decreases negative attention from our classmates. So if I keep saying, Lauren, pay attention, Laura, pay attention, right? All of my classmates are now looking at me, and now I'm in a whole different thought process. Providing timeframes and warnings. This promotes expectations of transitions, which can be really hard. And it also allows teachers to provide a clear expectation of when to complete something. So often we hear, well, I'm not done yet, I haven't finished yet. This is then having a teacher say, we can finish this in independent work time, or let's put that in your folder to take home with us tonight. Then looking at the communication with parents, it's not just a teacher to a parent or vice versa. We want to make sure that is cohesive and very open. This allows not just for like any updates of like things that are happening at home for a teacher to be aware of, but also highlighting some like or talking about some highlights and challenges. It is not a shaming tool. I think sometimes that can be scary for a child of my parents are receiving a note of how I did every single day, right? Like, you know, Lauren had some big feelings today. Doesn't mean that Lauren talked out of turn 16 times today, right? We want it to be constructive and positive so a kid doesn't feel like I'm nervous to bring home that notebook. Lastly, even just having some type of folder or binder that can say stay at home or return to school, that can help promote that field trip slips get signed, make sure that homework is being turned back in. Just that communication all around is really helpful. Next, we're going to look at social interactions. So to start off with the preparation for social interactions. So when we prepare for play dates, birthday parties, even just going to the park for an afternoon, that can change an experience for your child. So preparation can include giving expectations, reminding them of familiar details. So I don't know, Brittany from your class is going to be there, we're meeting them, or even providing strategies or reminders of strategies that they can use if they start to become frustrated, start to get bored. When we look at practicing perspective taking skills, we want to remember kids learn from their environment. And often we just overlook an opportunity to teach social skills. So parents can practice this by bringing awareness to others' feelings, statements that are made, and even behaviors to create a positive dialogue with their children. Acknowledging positive socialization and feedback, not judgment, those can sometimes go together. So when our comments are solely focused on negative interactions, a child's self-esteem, comfort zone, and openness is impacted. If we acknowledge things such as you did a really good job taking turns on the swing, or that was really kind of you to ask if she was okay after she fell, this helps reinforce those positive socialization skills. Some of the language we use can also be impactful. So thinking of could, not should. When we think of asking a child, like, what could you do when you get frustrated, or what could you have done differently? This helps a child determine their own personal choice and decision compared to someone telling them what they should or shouldn't have done. Next, we'll think about modeling. So this is parents showing or providing that opportunity for children to see them in that action. And as humans, we interact with others often. So when our children are with us, this gives us a chance to show them positive interactions, and also how we handle the ones that aren't as positive. So that could look like walking away, apologizing, addressing concerns in a healthy manner. I hear often, well, my parents just don't get mad. And I'm like, they do, but how do they handle that, right? As adults, we regulate and manage that a lot in our mind versus outwardly, but that is a great modeling opportunity for your kids to see what you do when you feel that way. And lastly, we're going to look at interests. So we all have hobbies, things we like to do. Learning what your child is interested in, you can then use that as a bridge to make positive connections. So whether that is Minecraft, whether that's the Bluey show that is always on at my house, right? Like that helps us find those different connections for kids to relate to. This then brings us to our executive functioning skills. So lastly, for strategies and techniques, we're going to look at the specific areas of executive functioning and then the connected techniques. So we'll briefly cover these. When we look at organization, that can be color-coded folders, having a designated workplace at home for school, using a calendar or planner that a child can interact with. Looking at task initiation, this can be a to-do list, setting timers of, all right, we're gonna work on math for 15 minutes, that's it for right now. Setting rewards, and then manageable tasks. If it feels like too much, it's gonna be really hard to start it. Self-control is going to look at that emotional regulation and that impulsivity. So having calming strategies, taking a break, thinking of a red light before I respond or react, and then thinking about the outcomes. Our working memory, it can be helpful again to have visual reminders, have repeated instructions back, having checklists, just do one thing at a time. We can't do everything all at once. Looking at planning, that can be utilizing preparation. How do we prioritize what we need to take, what we need to do or take on first? Having a homework log can be really helpful between school and home. And then management, again, manageable goals. If I say I'm going to read 1,000 books in the summer, but I know it takes me way longer than a week to read one, like, let's make sure that they're attainable. And then looking at time management, so estimating how long something can take us. Do I have enough time to start this? Having a schedule or communicating what is expected in a day, breaking it down, and then checking in to make sure how things are going. Then our last 3 executive functioning skills we're going to look at is attention. So even just acknowledging what is distracting. Is it noises? Is it movement? Is it tapping of a pencil in a class? And then figuring out what is your child's indicators of focus. Is it when I am looking at it? Am I repeating things back to myself? Having signals, again, with teachers that can be discreet, and then making sure our physical needs are met. Am I thirsty? Am I hungry? Did I sleep okay? Flexibility, we talked a little bit about this with routine, but this helps us provide or promote that problem solving strategies or techniques, thinking of alternatives. What else can I do rather than what I originally planned? Then having some conversations about positive past experiences that we did handle something not going according to plan, or how we problem solve something. And then lastly, our perseverance. So this is going to be our positive self-talk. Why am I trying to do this? What is the benefit or outcome for completing this task? And just encouraging ourselves, or parents encouraging their their children. All right. So tonight we're going to wrap up with just an overview of some resources and support, and that's going to surround educational plans, community resources, and also parental support. So to start off with, we'll look at those educational plans that I first talked about in the school interventions. So there are 2 different laws that are in place to protect the rights of students with disabilities. The first process of each plan is to have a documented disability that impacts life activities, such as learning. One statute is the IDEA, which is protecting funding for special education. And then the 504 statute is a statute for federal funds to help provide non-discriminatory services, which can include accommodations. So you'll see in this diagram that our first piece is going to start an educational plan is to submit a letter to request an evaluation. Contacting your school can help provide guidance on how to submit that formal request. Does it have to go to a certain person? Then from there, an evaluation is conducted, and that then determines if a student is eligible for an IEP, which is an individualized education plan. If a child is not eligible for an IEP based on the school evaluation, families have options of what to do next. You can request an independent educational evaluation. So this is an outside evaluator other than what the school used. Or you can request a 504 plan, or you can lastly ask for a due process hearing to make sure that it was appropriate evaluation to rule out the eligibility. From there, depending if it's an IEP or a 504 plan, these are then a plan created of a team, whether that's special education, whether that is family members, students, teachers, everyone comes together to create a plan that includes accommodations, interventions, services, and programs to support the educational goals and needs of the student. The few differences between the IEP and the 504 is that an IEP requires special education interventions where a 504 doesn't. So that is the big difference of depending on what the different requirements or needs are for that student. And next, you will receive these in an email, I believe, in the next couple days, but these are just some different websites that can be helpful, talking about programs, agencies, fact sheets, and then also the processes to support education plans, and also provides information on knowing your child's rights specifically with education. And next, we put together some different books for parents and also for children of just learning more information about ADHD. What are things that can be helpful for parents to do? In the books for children, there is some educational fun books, but also workbooks that help build those skills and techniques as well at home. And we also have a slide of helpful websites for parents. So again, touching base on just understanding the diagnosis, what are some next steps? There's some really great supportive websites out there of just learning, whether that's discipline, whether that is emotional regulation, just knowing that there are resources out there that can be helpful. So lastly, we will have Dr. Raburn touch on the helpful resources for medication.
So just a few resources here to leave you with on the medication specifically. I really like ADHDmedicationguide.com. It's a visual representation of the medications used for ADHD. The next resource is a bit comprehensive, but it was made by psychiatrists for caregivers. So if you're interested in checking that out. Lastly, I thought this ADHD medication log was helpful. It's designed by understood.org. It can help keep track of taking medications, side effects, and target symptoms. So to recap, ADHD is a common chronic condition in children. Other medical or psychological disorders often co-occur with ADHD. ADHD treatment is effective, but treatment needs to be ongoing, and symptoms may change over time. By developing their strengths, structuring their environments, and using medication when needed, people with ADHD can lead very productive lives.
Okay, so it is time for the Q&A portion of tonight's presentation. If you would like to ask a question, please type it into the Q&A feature, which again is at the bottom of your Zoom screen, and it'll be 2 speech bubbles with the letters Q and A. And do not type them in the chat because we may miss them. So one question we have right off the bat, do you have any suggestions for teens that may vary from a younger child?
Yeah, I would say, you know, we did focus on a specific area because ADHD is a very broad topic to cover. I think a big piece is understanding what strengths and skills your child has, your teen has, and build on top of those, right? So when I think of kids that, I shouldn't say kids, teenagers that focus on their video games, they love those, they can focus, they're beating all these levels, right? Like breaking that down, what skills does it take to be able to move from level to level? There are those websites that we did put in for supportive for help. There's one that's called Attitude Mag. They break it down into different age ranges as well. There's also some different accommodations and strategies for older children as well. So there's some different techniques, but I think, finding what your kid's interested in, building on the strengths that they have and the skills that they're utilizing outside of school, those can be a really helpful starting piece.
And ultimately, starting the conversation with your pediatrician is probably the first step, and you will get the care that's appropriate for your child's age, correct?
Yes,
Right.
so a big piece we want to make sure that we share is if there's any specific concerns or questions surrounding your child and ADHD, please connect with your pediatrician. So again, like Dr. Brittany mentioned in the beginning, we are not experts in this area, but we do work closely with it in the pediatric primary care setting. So getting connected with your pediatrician will be the first process of exploring those next steps and moving forward.
Okay. So I think that if a family doesn't have a great connection with their child's teacher during a particular year, are there other resources within the school that could be brought in, a third party that can kind of mediate or help maybe mend some of that communication to make it a little bit more productive?
Yeah, I think depending on school districts, depending on specific schools, their resources can look different. So in general, connecting with a school, either social worker, a school counselor, an advisor, even talking to some of the admin there. So I get it. Sometimes we don't have a great connection with our teacher, and that can be hard when that's who we're asking to provide feedback from. So even just looking at your school's social supports or even just additional admin can be helpful of getting those connections started, at least in the school.
Yeah, and then also Michigan Alliance for Families, I think was on as part of one of the resources that we put together. They're also a wonderful resource to reach out to, in addition to that chad.org as well, and they might have some ideas as well.
And kind of just piggyback on that as well. In those resources for education, there's Student Advocacy Center, which also works very closely to make sure that students' rights are being respected and things are taken care of. So if there's ever an issue with communication, again, those are helpful resources to make sure there's support in place for that.
Perfect. Okay, there's a question around non-school community services. Are there any that you recommend, such as behavioral therapy, OT, or an ADHD coach?
Dr. Brittany, do you have anything specific you want to add to that?
Not in particular, other than, just going back to kind of those resources, that chad.org, they have local chapters, which are really nice. And so I think that might be kind of a nice community to tap into to get kind of more of those local resources.
So this is sounding like it's definitely not a one size fits all treatment plan. But if there is a diagnosis that leads to either OT or speech therapy or other types of therapies, that is something that your pediatrician can help connect you with as well, correct?
Without a doubt. Yep. We can work with our referral coordinators to get you involved with either, private speech or OT, or again, kind of relying or going back to the school and seeing what resources can be done through special education.
Okay.
And I do feel like that it is very individualized to each individual. So to say, okay, behavioral health is the way to go, or parent training or OT, like really we want to think about it as a collaborative care model of making sure that our physical symptoms are managed, our educational piece, our behavioral, our occupational, and finding, creating that individualized treatment plan for that specific child is really important.
And it sounds like when you're stepping into ADHD treatment, to have an open mind for a test and learn kind of a strategy. So whether it's medication or different types of therapies or approaches, it's about figuring out what works for you or your child.
Right, exactly. And even going back to that neuropsych testing that can really fine tune and say, oh, we really need to work on the OT aspect here, or, whatever different avenue that specific child might need.
Okay. So if you at home are finding that modeling behavior is really helpful to your child, is there anything you can do to help or recommend modeling at school? Is it possible to say, certain, I don't want to say students, like not comparing to other students, but is there a way to show, okay, this is appropriate behavior when the teacher is speaking based on this other student's behavior? Or is there a way to kind of pull that into school or times where the parent isn't there?
Yeah, I would say sometimes, I hate to just keep saying this, but like it does depend on like the school, the teacher. I've had some great conversations with some teachers that, without any type of accommodation plan or IEP, they talk about this like, because school isn't just about like the curriculum, right? It's about the social skills, which has been a big impact on our children the last couple years through a pandemic, right? Like learning through a screen looks very different than sitting in a classroom at a table or at a desk. And so, that can be something, whether that's at parent-teacher conferences, whether that's at just communication starting up the new school year, of just saying, hey, we're really working on modeling and understanding appropriate child interactions or class interactions. Is there any way that you can bring some of those pieces in, whether or not a child has a plan or not? So just having that communication with the teacher can be helpful. But I do think it's hard because a parent isn't at school to be like, that's what we're supposed to do in class. And that's sometimes not always appropriate. So just having those conversations to get that support can be helpful.
Okay. Is there kind of a fine line, or do you have a talking point where you can kind of give that advice to your child constructively, where they don't walk away feeling like they're being compared to another student and saying that student's better than you? Because is there just like a line that, or kind of a conversation starter that you can use, whether it be in school or maybe you're out at a movie, and you want to show, well, this is how we sit at the movie, without saying, you're not behaving as well as that student?
Yeah, I think there are some ways, without giving words verbatim, because it definitely depends on a kiddo and the situation, but really just being, understanding, validating, right? So even, if someone says like, I kind of mentioned that like could, not should, right? Like you should be sitting still in a movie. You shouldn't be kicking your feet, right? Like even just that piece, right? So if we flip that and say, hey, could you see how, like, how do you think you would feel if someone was kicking your chair, right? I'd probably be frustrated. I'd probably be ignoring it, right? Trying to get them to connect and almost like that piece of empathy of like, oh, wait, how would other people feel? Or even using situations like that, right? So I know if someone's like screaming in a movie theater, right? Like that can be very frustrating. But if I'm the one screaming, I'm like, well, it doesn't matter, right? So trying to just change that a little bit for them to see from that point of view. And I don't think there's one key sentence to define that line of like, you're doing something wrong or good or things like that, but really trying to stay away from some of those like strong words of like, you were a good boy at the movies today, right? Use a specific skill that they used. Hey, you were really patient waiting for our popcorn today, right? It looked like you had a really hard time waiting in line for our tickets. So those can be different pieces without being like, again, those judgment pieces.
Okay, perfect. So I would say when I became a parent, I learned very quickly that a lot of skills do not come naturally. It's definitely a learning curve to be a parent. So if you have a moment where maybe anger gets the best of you or anxiety gets the best of you and you don't behave in a way that you would have liked to, so maybe you raise your voice or you say something that didn't come out exactly right, can you approach that to repair that with the child? maybe it's at the end of the day or once things calm down, but calling out where you feel like you made a mistake.
Yeah, I am a big one for, right, like taking that accountability. I think it's huge for our children to hear adults say, hey, those feelings got the best of me. I responded in a way that I know didn't make me feel good. How did it make you feel when I said that or I yelled? And that just shows that adults are humans. And, then that promotes this idea of like forgiveness, right? Or this concept of forgiveness. They may hold on to that feeling for a day or so, but knowing, hey, how did that feel when I said that? What were some things, and just providing that understanding. We're all humans. Whoever it may be can get upset, but I'm now coming back and saying, this is what I could have done differently.
And is there an aspect that, or when you talk to parents, is there an aspect of it where we say not to take things personally? So an angry child may say something that, really cuts to your heart when you're a parent, or they may say like an I hate you statement or something negative about themselves. So is there like an aspect of that where you would say this isn't personal, it's the anger coming out or anxiety coming out?
Absolutely. I know in some of our previous Wednesday wellness with our behavioral health therapists, we talk about big emotions as a tunnel, and for whatever reason we step into that tunnel, we're not hearing anything, we're not processing anything until we get to the end of it. And so we can sometimes hear these very hurtful comments or like, oh, that one just got me, right? They knew exactly what to say to pull on those heartstrings. And just reminding ourselves like we're in that tunnel right now. We can come back and have a conversation as far as like how, like, the reasons why that was hurtful or how come we said those things. We often see once we come out of that tunnel and we come down from those bigger emotions, there's a lot of remorse, there's some guilt, there's some shame of saying those things. And so without placing additional negative weight on those comments, just saying like, hey, that with you saying, I hate you or whatever it may be, that meant a lot to me. Tell me what you were feeling, or tell me where that came from. And sometimes they're like, I don't even know I said that, or I said it right then, but I really don't mean it. And it's just using, that opportunity to show self-control, that our words have weight. And if we learn some of these skills to say, okay, if I say this, do I really mean it? If I say this, what are the outcomes of saying that, right? Some of those processing skills that are sometimes need a little bit more attention and time to be taught versus just coming naturally.
I love starting the statement with a tell me statement or a question to a child. It seems like that's a great way to kind of give them a chance to express their own feelings in the situation or their own experience.
And it gives them, right, their own voice, right? Because we can be in the same situation, but the way I see it can be very different from a 7-year-old and how they saw it, right? So like, tell me what was going on in that moment, and that then gives them something to focus on and to say, okay, this starts that processing moment, rather than just being like, I'm angry and I don't want to do anything. It looks just a little bit different.
Yeah, that's a great conversation starter. It seems even when maybe asking about a school day or whether things that they maybe were proud of or things that maybe didn't go so well for them, having that tell me statement seems very powerful. I wanted to ask so we talked a bit about autonomy and giving these your children the ability to kind of be independent where they can be. I imagine that isn't limited really, like any opportunity where they can really express their individuality and their independence sounds like an opportunity where they can kind of feel that excitement or success on doing it themselves and something on their own. Can you work that into, chores and kind of like everyday life throughout the day?
Absolutely. I talk a lot about what we have control over and what we don't have control over. So, when I think about some of the younger ages, I talk about, do you want to put your pajamas on first? Do you want to brush your teeth? Do I really want toothpaste on your pajamas? No. But I am now giving, like, if bedtime routine is a hard process, I'm now giving you some, like, a say in that, right? Thinking about snacks. What do you want to take to lunch? Are you taking an orange? Are you taking grapes? Right. So it doesn't have to be these, life-changing decisions we're offering on a regular basis. But when we meet this need of control, we're meeting that in different ways rather than refusal. Because when we see those refusal or that reservation to doing tasks, they're hanging on to that control because they know what to expect and they know how to prepare for not doing it. So when we offer those different opportunities, it's not about saying you can do whatever you want. The parents setting those boundaries, but they're then again promoting that autonomy or independence for choices.
So maybe would it be helpful as you're kind of laying out some of these changes, if you make those changes in some of your routines, laying out things that are non-negotiable versus things that are, like you said, I don't love the idea of you getting toothpaste on your pajamas, but it's a place where you can make a choice versus you cannot run into the street. Like you can't make a choice on that. So kind of like looking ahead versus making choices or making those decisions kind of in the moment.
Yeah, I think, every household looks different. Every family can work different, especially when we have, multiple homes for a child, having some type of just clear expectations, right? So like if even just being outside, right? Like we don't go outside unless an adult's with you, right? Or we don't cross the street unless your brother's with you and you look both ways, right? Like still setting those dynamics, or those expectations and, like you said, non-negotiables, but we're also meeting that with that option of choices and decisions so it doesn't feel like one-sided all the time.
Perfect. Dr. Brittany, can you tell us, are there a couple ways that you can start this conversation with your pediatrician? I know sometimes it can be hard to find the right words to express what's going on in the house, especially if you're in the room with your child.
Yeah, definitely. You mean, so the initial conversation,
Yeah.
getting to talk to your pediatrician, usually, you'll call the office and you could just ask to talk to a nurse. And usually, could just say, I have some behavioral concerns is kind of a nice broad encatchment that I'd like to discuss with the doctor if you're not, if you're not comfortable relaying those specific questions. And then often, the nurses will send us kind of a message and we can kind of come back and come up with a plan, what's going to be the best way to talk to that parent. We do have so we can talk to the parents by themselves, and consultation often can be an option if you're not comfortable talking in front of your child.
That's so good to know, because as a parent, I often think like I need to hold on to all these questions until that annual exam or that wellness checkup. But really, we can call at any point.
Oh, anything, yeah.
We request that.
Yeah, definitely, anytime. And I think, that's another reason to just advocate even more for those, coming in for those yearly check-ins. Is really just to see where things are at and continuing that relationship so that it doesn't feel like, oh, it's been 2 or 3 years since I've talked to my provider, and coming with so much at that point. So, but yeah, keeping up with the annuals is a great thing. And then definitely feel free anytime. That's what we're here for.
That's a great thing to remember. And if your child is put on a medication to treat ADHD, are you seeing the child on a more regular basis than annually? I assume more often as you're figuring out which medication is the right one for this child, but how do those like medication appointments look?
Yeah, so we see children on ADHD medications at a minimum of twice a year. So that's usually at your annual checkup and then a 6-month follow-up. But you're right, when we're first starting those medications, you're going to be seeing us quite frequently. If everything goes well, usually we see you at the first like 2 to 3 weeks out from the initial consultation. And then say we did a good job with the medicine, we're doing well and we're continuing that dose, then we can space that out to every 3 months for a couple of visits, 3 months and then 3 months. And then you get on that 6-month follow-up. But if we're really having, some fine tuning, I'll usually see patients back at least every month as I make a medication change, if not sooner.
Okay, excellent. So thank you so much. You guys have gone over about 15 minutes answering questions. We appreciate this discussion. This presentation was so comprehensive. I just wanted to download it all into my brain to remember always when interacting with my children. But for those of you who are still on, you will receive an email. It will have all of those great links and suggestions that Lauren and Dr. Brittany shared in the presentation. And we will also share a recording of this presentation so you can watch it over again. So thank you so much to both of you, Dr. Brittany and Lauren. We appreciate your expertise in sharing this important topic.
Thank you.
Of course.
Thank
Thanks
you all
for
for your
everyone
time.
joining.
Absolutely. Have a good evening. Thank you.
You too. Bye-bye.
Bye.